Those of us here at Colorado State University are proud to share with you this session of Endoscopy Talks. When you're looking for inspiring veterinary CE experiences, think CSU Vet CE. Nestled up against the Rocky Mountains in our new State of the Future facility, we invite you to experience what we call CE Elevated. We'd love to see you in one of our future on-site, online, or blended courses. Check us out at www.csuvetse.com. Now, please enjoy Endoscopy Talks.
Hello, everyone, and welcome to Endoscopy Talks. I'm Ross Palmer with CSU Vet CE, and I'd like to thank you for joining us on behalf of Colorado State University's Translational Medicine Institute. Today, we're joined by Dr. Jean-Guillaume Grand, diplomat of the American College of Veterinary Surgeons from the Bordeaux region of France. He leads the orthopedic service at Aquavet Veterinary Referral Surgical Specialists, one of the prime centers for advanced veterinary orthopedic surgery in France. Dr. Grand's topic is a very popular one: how to avoid or minimize complications in small animal arthroscopy, something I'll be very interested in hearing and learning about. So without further delay, I'll turn the session over to Jean-Guillaume.
Thank you, Ross, for this short presentation. It is really a great pleasure to be here this evening and share some experience with arthroscopy. Just before starting this presentation, I specify I have no conflict of interest to declare, and I am not paid for giving this presentation. Just to give you an overview of our discussion for this morning, this webinar will review scenarios during which arthroscopy is performed. It will focus on discussing benefits and limits of arthroscopy for the patients. Some factors are often associated with surgical failure and disappointing results for the patient and the surgeon as well. Wrongly, arthroscopy is often described as a low risk or a no complication surgery, but in fact, many intra and postoperative complications may arise. Regarding surgical complications associated with small animal arthroscopy, there is clearly a lack of information in the literature. If you have a look on a PubMed search using 3 keywords, such as complications, dogs, and arthroscopy, you will find only 3 publications specifically dedicated to complication in canine arthroscopy. Among these 3 publications, 2 are retrospective studies and 1 is a case report. And this is my first question to you. In your opinion, what is the overall complication rate associated with elbow arthroscopy, which is the most common arthroscopy performed in small animal surgery? Would you say that this rate is about 2%, 10%, 35%, or 50%? If you have a look on this retrospective study, published in 2013 in the VCOT and conducted in 750 elective elbow arthroscopy in dogs, complications necessitating repeat surgery were documented in about 5% of cases, and those complications were described by the authors as major complications. The most common reason for repeating surgery was a recurrent or persistent postoperative lameness of unknown etiology. Minor perioperative complications were documented in about 17% of cases, and the inability to treat arthroscopically the lesion with unplane conversion to arthrotomy was the most frequently reported complication in this category. Other minor perioperative complications included technical difficulties with the arthroscopic instrumentation, excessive intraoperative hemorrhage, significant iatrogenic cartilage damage, fluid extravasation impairing arthroscopic inspection, and the absence of definitive diagnosis, meaning that the arthroscopic inspection was probably not complete. Minor postoperative complications were reported in nearly 11% of cases and included a worsened postoperative lameness with no repeat surgery performed, severe postoperative pain and joint swelling, infection, and temporary postoperative neuropraxia. And finally, this gives a total complication rate of 35%, which is finally pretty high for elbow arthroscopy. And I am pretty sure that many of you would not have expected to have a so high complication rate associated with a recognized simple procedure like elbow arthroscopy. So if I had to answer to this question, how to avoid and minimize complication in arthroscopy, I will tell you that. First, define the role of your arthroscopy in order to avoid unnecessary surgery for the patient and unsatisfied owners. Second, plan your arthroscopy as you would do it like for any other surgery. And finally, apply key elements for well-executed arthroscopy, including basic principles for arthroscopy. If you look at what is arthroscopy, there are several definitions. One of them is to define arthroscopy as a minimally invasive surgery. Minimally invasive surgery is about minimizing our footprint as surgeon by optimizing tissue handling and creating the least amount of tissue disruption while achieving the objective of the procedure. If you perform an arthroscopy, keep in mind to minimize joint trauma. Otherwise, you will lose the benefits of MIS for the patient. And for arthroscopy, being minimally invasive, it's not only doing very small or keyhole incisions, it is mainly taking care about the articular cartilage and periarticular soft tissue structure. Do not forget, the benefits of arthroscopy for the patient are also related to your surgical expectation. And here is the first thought. You have to go back to the role of your arthroscopy to be successful. And this role should be clearly discussed with the owner during the consultation time. The first question that you may ask is, should I go for a diagnostic or an interventional arthroscopy? And we need to address case by case the role of arthroscopy to be successful. And to answer to this question, source the pre-op images. If you have a look on this case on the right side of the screen, suffering from a fragmentation of the medial coronary process without any obvious osteoarthritis, it is, in my opinion, a very clear and nice indication for an interventional arthroscopy with the goal to remove the fragmented medial coronary process. If you look at this case now, suffering from the same primary lesion, a multiple fragmentation of the medial coronary process, but with a massive osteoarthritis localized in both the medial and the lateral compartment of the elbow joint, there is no point, in my opinion, to recommend an elbow arthroscopy with the goal to remove the fragmented MCP, because this dog is suffering more from osteoarthritis and not really from the primary MCP lesion. And performing an interventional arthroscopy in this case with the goal to remove the fragmented MCP will probably lead to disappointing results, unsatisfied owners, and a frustrated surgeon. However, arthroscopy remained in this case perfectly indicated for cartilage staging in order to define which kind of elbow replacement technique you may use in the future. I mean that if at the time of the arthroscopy, the cartilage lesions are localized only in the medial compartment, it is potentially an indication for some additional procedures such as a Q, a POL, or an SHO, as described previously by Fitzpatrick. In contrast, if the cartilage lesions are localized in both the medial and the lateral compartments, it is not an indication for those previous surgery. It is an indication for conservative management or a total elbow replacement technique. Surgical exploration via arthroscopy may be used to achieve definitive diagnosis, to determine the severity of the lesion and allow for subsequent treatment. This dog presented for a right forelimb lameness with shoulder pain and increased abduction shoulder angle. Shoulder arthroscopy was proposed to the owner with 3 goals. The first one was to confirm the clinical suspicion of medial shoulder instability. The second one was to determine the severity of the lesions on the medial compartment of the shoulder joint. And finally, to decide if we have to go toward a conservative management or if we need to plan additional surgical procedures such as medial shoulder stabilization. In this case, when we did the shoulder arthroscopy, we confirmed the initial clinical suspicion of medial shoulder instability. And we can see some marked fibrillation on the subscapularis tendon and a partial rupture as well of the cranial arm of the medial glenohumeral ligaments. Nevertheless, in this case, the lesions were not as severe as we expected, and we finally decided to go for a conservative management with rehabilitation therapy, and hopefully the dog had a very nice recovery when he was seen at the time of the recheck 3 months later. If you have any doubt about the role to give to your arthroscopy, do not hesitate to check with a network of experienced surgeons, and you may use different kind of platforms such as the endoscopy talks with conversation with vet experts, but you may use as well other communities like the SVOT or the AOVET platforms. Maybe, Ross, we can do just a short break if you want to, if you have some question.
Absolutely, we do have a few questions. One is, do you think that the complication rate is related to the experience of the surgeon?
Definitively, yes. I would say, like for any other surgery and any other orthopedic surgery, the complication, we have very few data about the complications in arthroscopy, but my feeling is that the complication rate depends on the surgical experience of the surgeon and depend as well of the joint that we scope. Even if we do not have any study comparing the complication rate for elbow joint arthroscopy versus shoulder or stifle joint arthroscopy, my feeling is that the complication rate associated with stifle arthroscopy will be probably higher compared to elbow arthroscopy, especially if the arthroscopy is performed by young arthroscopic surgeons. I do not think that this complication rate will be significantly different if the surgery are performed by experienced surgeon.
Okay. And then what is your sort of speech or your discussion with owners regarding possible complications associated with arthroscopy?
Yes, that's a good question. I am insisting a lot when I am talking to my residents. Owner consent and owner information is mandatory. We need to inform at the time of the preoperative consultation for the goal of the surgery. So we need to explain clearly to the owner if we go for a diagnostic or if we go for an interventional arthroscopy, because the goal is not the same in both cases. And we need to explain as well to the owner the potential complications associated with arthroscopy procedure. And I am always talking about the possibility to convert to open arthrotomy at some point. Maybe if we have some intraoperative complication, or if we cannot do the job using arthroscopy.
And then one last question, and you alluded to this a bit in your discussion, but perhaps more detail, is how do you select cases for arthroscopy in case of medial coronoid process disease?
Yeah, that's a nice question. I do not think that all dogs suffering from medial coronary process disease should have surgical treatment and should underwent arthroscopy. My feeling is that, in my experience, I am proposing arthroscopy for treating the medial coronary process only when I have a very clean joint without osteoarthritis or with very few osteoarthritis. I do not think that the arthroscopic treatment will provide some benefits to the patient if we have some osteoarthritis in the joint. And if we have a look in the literature, we do not have any publication mentioning that the arthroscopy is beneficial for dogs with osteoarthritis and medial coronary process disease.
Very good. It looks like that wraps up our questions for this part one. So why don't you continue on, Jean-Guillaume, to part two?
Yeah, let's start. Planning an arthroscopy assumes that the surgeon is familiar with the arthroscopic instrumentation. In other words, do I have the proper equipment for doing it? As an example, you cannot do an elbow joint arthroscopy in an 8 kg dog with a 2.7 millimeter arthroscope. You need to use a smaller one, like the 1.9 millimeter arthroscope. And even if you succeed to enter inside the joint, you will probably induce some important damages to the joint and mainly to the articular cartilage. This is another example. This cat presented 10 days ago to our hospital for right forelimb lameness, secondary to a partial biceps tendon rupture. And the biceps tendon release was performed under arthroscopy in this case using a 1.9 millimeter arthroscope. And I could not use a bigger one. I could not enter inside the joint with the 2.4 millimeter arthroscope. So think about that. And if you think that you do not have the good instrumentation for doing arthroscopy, it is probably better to refer the case to another surgeon. Like for any other surgery, have a plan B before going to the OR. If maybe one of your plan B will be to call someone else if another surgeon is available in your hospital. But if you are by yourself, a better plan B is probably just to convert to open arthrotomy. And conversion to open arthrotomy require conventional orthopedic clipping. So your dog must be clipped correctly for open surgery. And the surgeon, of course, must know surgical approaches for open surgery. So just think about bringing your parachute with you when you are going to the OR. The last question that you may ask is, should I be the one doing this? I mean that if you are not properly trained for doing arthroscopy, it is probably better to refer the case to another experienced surgeon. The use of diagnostic imaging may be a great help for the surgeon for planning arthroscopy. This case experienced recurrent lameness 6 months after successful surgical treatment of a comminuted distal femoral fracture due to an intra-articular non-loosening screw causing joint impingement. And the question we had preoperatively was to know if we could remove this screw entirely by arthroscopy. And to answer to this question, we did in the preoperative period some additional radiographic views. An additional view was performed with the knee joint flex at 90 degrees in order to determine what is the approximate orientation to give to the screwdriver for extracting the conflicting screw. And this view showed that the correct orientation of the screwdriver was roughly parallel to the cranial tibial plateau with the knee joint flex at 90 degrees. And that's we have done during surgery. A standard craniolateral approach was performed to the knee joint, and the instrument portal was created in the medial compartment of the stifle joint, close to the tibial plateau and close to the patellar angle. The screwdriver was introduced inside the joint with the knee joint flex at 90 degrees, and the screwdriver was inserted until we reach the screw. The screw was removed entirely by arthroscopy. And we were pretty happy with that because finally we succeeded to remove this screw and we provided a minimally invasive access to the joint. And the main advantage was finally to avoid a medial arthrotomy and to limit the risk of infection and secondary patellar luxation. The use of CT imaging is also a great help for the surgeon for planning arthroscopy and to choose the most appropriate surgical approach for arthroscopic inspection. And this is my second question. Which of the following arthroscopic approach would you choose in this case, suffering from an OCD lesion of the tarsal joint? Would you go for a dorsolateral approach, a plantaromedial approach, a plantarolateral approach, or a dorsomedial approach? You probably know two different locations are typically described for tarsal OCD lesion. The first one is a tarsal OCD lesion located on the dorsal part of the talus bone, and this lesion requires a dorsal arthroscopic approach. In contrast, some OCD lesion may be located on the plantar aspect of the talus bone, and this lesion requires a plantar arthroscopic approach. On the top of that, the surgeon must also choose for the positioning of the arthroscope. I mean that the arthroscope may be positioned in the lateral or in the medial compartment of the tarsal joint, and whatever if you use a dorsal or a plantar arthroscopic approach. The general rule is always to put your arthroscope directly opposite to the OCD lesion. So if the OCD lesion is located in the medial compartment of the tarsal joint, then the arthroscope should be placed in the lateral compartments. And this is an important point because the location of the portal in arthroscopy can make your life easy or very difficult. If we go back to our cases, which of the following arthroscopic approach would you choose in this case? If you have a look on the left picture, this is the sagittal CT view. This view showed that the OCD lesion is located on the dorsal part of the talus bone, so a dorsal arthroscopic approach is needed. On the right CT frontal view, we can see that the lesion is located on the lateral trochlear ridge of the talus, so the arthroscope should be positioned in the medial compartment. So the correct answer is a dorsal medial approach for this arthroscopy. The use of CT may be also a great help for planning advanced arthroscopic surgery like subtotal coronary endoscopy. Subtotal coronary endoscopy is indicated in cases of medial coronary process fragmentation, fissuration, or in case of cartilage lesions over the medial coronary process. The subtotal coronary endoscopy may be performed by arthrotomy, mini arthrotomy, or entirely by arthroscopy. Whatever the surgical approach that you use, the most important point is to do your arthroscopy all the time distal relative to the dot line, because this dot line is defining the most caudal part of the radial head or the most cranial part of the radial incisor. And if you do your cut at the level of the dot line or proximal to this dot line, you will be in trouble at some point because you will create a fracture inside the ulna. If you perform an SCO in these cases, have a look first on the native CT images because they are important variation in the morphology and the dimension of the medial coronary process. Some dogs may have a very short and large MCP, while other dogs may have a very long and narrow MCP, like in the right picture. In conclusion for this part, planning arthroscopy is one of the keys to success. And the adage that say failure to plan is planning to fail, which is a very popular adage in orthopedic surgery, is also valid for arthroscopy.
So thank you for that. That was great information. A few questions have come in. One, and you touched on it, but I think this is a very good question, is do you see the incidence of complications as being different when your procedure is performed through an open surgical technique versus an arthroscopic technique? So you mentioned during implant removal that one of your justifications was to decrease the likelihood of a surgical site infection. So is your impression that infections are less likely through arthroscopic procedures?
To be honest, I am not doing any arthrotomy for managing MCP cases for a long time ago. I am doing only arthroscopy in those cases. My feeling is that some rate of complication are very low. An infection is a very rare complication associated with arthroscopy surgery. A couple years ago, one author published an interesting study about more than 300 arthroscopy in dogs. And this author reported a very low complication rate, especially for infection, because the rate of infection was less than 1%, which is significantly lower compared to the rate of infection that we can find with open surgery, in orthopedic surgery at least.
Okay. Another question is regarding arthroscopic instrumentation. Do you need a shaver for starting in arthroscopy?
Yeah. It is a frequent question that I had. In my opinion, the shaver is a very nice tool in arthroscopy. But when you are starting with arthroscopy, you do not need to have a shaver to perform arthroscopy. The first step when you start arthroscopy is first to complete inspection of the joint, and whatever, if you do arthroscopy for the shoulder, the stifle, or the elbow joint. And for most of the diagnostic arthroscopy and for inspection of the joint, we do not need to have a shaver. I would say that for those cases, the shaver may be interesting in chronic cases of cranial cruciate ligament disease, because in those cases, we have a lot of membrane, of synovial membranes proliferation, it can be difficult finally to see well the menisci in these cases. But except for those cases, the shaver is usually not needed for diagnostic arthroscopy. And for interventional arthroscopy, the shaver is interesting if you need to debride cartilage and bone. A good example is for the treatment of OCD lesion, or if you want to do your curettage of the medial coronary process using the shaver. But definitively, if I need to choose between the shaver and an arthroscopic tower, if I have some financial constraints, I would go definitively for an arthroscopic pump before getting a shaver.
Very good. And then the last question for this portion is that some people, surgeons, but perhaps also pet owners, might confuse a failure to completely recover from an arthroscopic procedure as a complication. And so would you consider, first of all, failure to improve a complication? But then also, how do you discuss that with pet owners? Do you present that as a potential complication?
Yes. As I said at the beginning of this webinar, when I am talking to the owner during the preoperative consultation, I am speaking about the risk to convert at some point to open arthrotomy. And the reason may be variable. Maybe we could have some intraoperative complication, and maybe we cannot do the job properly by arthroscopy. And the way I present that to the owner, I think it is definitively better at some point to take the decision to convert to open arthrotomy if you cannot do the job by arthroscopy. Because if you spend 2 or 3 hours doing arthroscopy, I am pretty sure that you will create some important damages to the joint. And finally, you will lose all the benefits of minimally invasive surgery. So I would say that the unplane conversion to arthrotomy, it's not very a big deal. And even if this complication is considered as a major complication in some study, it's not really a big deal. I prefer to do correctly the job by arthrotomy and to have a well-executed arthrotomy procedure rather than to do a bad job by arthroscopy.
Thank you so much for that. And I so much agree that you always want to prepare the owner for that possibility of conversion and then explain the rationale for why I might convert. And again, it's always important to do a great job versus doing it minimally invasively. And so if conversion is required, I think that's a great suggestion. I agree with you. At that point, I think it looks like those are all the questions for this portion, so we can continue on to the third part of your presentation. Thank you.
Yeah. So let's start for this final part of this webinar dedicated to complication in arthroscopic surgery. This slide is a copy-paste of the lecture given by Dr. Laurent Guillot in 2018 at the time of the ESVOT Congress in Barcelona about minimally invasive osteocentesis for fracture management. But finally, the similar comments can be made for arthroscopy for joint disease management. The first time you see a well-executed arthroscopic surgery is when you really realize how this approach can change the course of a recovery for the better. The first time you try it is when you really realize how postoperative outcome could be negatively affected by it. And the first time you must convert to open surgery is when you wonder if you should have chosen an open approach first. Arthroscopy in the hands of well-trained surgeons offer the possibility to perform very elegant surgical procedure. And if everything goes well, it is a pretty cool surgery for the surgeon and the patient as well. In this dog suffering from a fragmentation of the medial coronary process, a radial fragmentation, which is surrounding the radial head, a subtotal coronary dostectomy was performed entirely by arthroscopy. For this, a craniomedial approach to the elbow joint was used for the arthroscope, and the instrument portal was established 1.5 to 2 centimeter cranially to the arthroscope portal. And a 4 millimeter osteotome was introduced under arthroscopic guidance inside the joint through the instrument portal. The osteotome was positioned on the abaxial part of the medial coronary process. And then with the help of an assistant, the osteotome was advanced until the medial coronary process was completely ostectomized. One of the advantages of this arthroscopic guided SCO is the possibility to remove the MCP in one block, and finally to limit the production of cartilage and bone debris inside the joint. Another potential advantage is to remove the potential microcracks located adjacent to the fissure of the fragmentation line, but you can't remove it only if you do your cut slightly proximal to the fissure or the fragmentation line. This is another critical surgery that you can do entirely by arthroscopy. This German Shepherd dog was suffering from an united anconeal process. And in this dog, the anconeal process was entirely removed by arthroscopy. For this, we used a medial approach to the elbow joint, and the arthroscope was positioned just distally to the medial epicondyle. And note that we switch the egress and the instrument portal. So the egress portal was finally placed in the cranial compartment, and the instrument portal was placed over the anconeal process for introducing a grasping forceps to remove it in block. The advantage of this arthroscopic surgery for the dog is to provide first a minimally invasive access to the joint, but also to avoid a lateral arthrotomy, which is commonly associated in these cases to wound-related complications such as seroma, dehiscence, or potential secondary infection. Regarding surgical execution, it is definitively better to walk off shame and to convert to open arthrotomy if you did not do the job properly by arthroscopy. If not, it's likely that you will need to go back to the theater several weeks or several months later. Remember, a well-executed arthrotomy is better than a poorly executed arthroscopy procedure. And finally, remember, intraoperative mistakes can occur at any steps during the surgery and are often cumulative. And I can speak to you about my first Irish experience. Just after getting the ECVS diploma, I moved from France to Ireland to the University College of Dublin, where I took a position of lecturer in small animal surgery. And for my first surgery, I had to perform a bilateral elbow arthroscopy in a lab suffering from a bilateral fragmentation of the medial coronary process. I was pretty happy, to be honest, with this start because I was confident with this kind of surgery. For the first elbow joint, everything went perfectly well, and we did the job very quickly, probably in less than 20 or 25 minutes. And when we started the second elbow joint, we also started with intraoperative complications. First, as I was starting the second elbow joint, the arthroscopic tower shut down. And despite several attempts, we could not turn it on again. Hopefully, we were at the university, so we used the arthroscopic tower from the equine department, and we could finally continue with the surgical procedure. And at the end of the second elbow, while I was finishing the curettage of the medial coronary process, the curette broke inside the joint. And despite several attempts to fix and to remove the broken metallic fragment, the broken curette migrated out the arthroscopic field and disappeared inside the joint. We tried to remove it by doing first a medial arthrotomy and then a lateral arthrotomy. We try as well using the help of the ultrasound examination, but at the end, we could not find the broken metallic fragment and we decided to left it in situ. Hopefully the dog had a full recovery and no lameness was reported at the time of the recheck 6 months later and 1 month and 1 year after surgery. But even if the dog was doing well, I remember very well of this day, even 10 years later. And I can promise you that this day I felt like a castaway. The first intraoperative mistakes typically occur during the surgical approach. The surgeon must have an excellent understanding of patient anatomy. And if you have any doubt about the surgical protocol for doing arthroscopy, it is definitively better to go back in the textbooks dedicated to small animal arthroscopy and just read again the surgical procedure. If you think an approximative arthroscopic approach will be probably okay, it probably won't. If you have a look on this left picture showing portals for a right elbow joint arthroscopy, the portal number 1 is defining the instrument portal. The portal number 2 is defining the arthroscope portal. And the portal number 3 is defining the egress portal. We can see on this picture that the arthroscope portal is well placed. The arthroscope is placed distally and slightly caudally relative to the medial epicondyle. In contrast, the position of the instrument portal is not correct because the instrument portal is too close to the arthroscope portal. And it's likely that with this configuration, the surgeon will not be comfortable at all for doing arthroscopic maneuvers. If, in contrast, the instrument portal is located too cranially, the risk is potentially to create some injury to some important neurovascular bundles. And that you can see on the right picture of the screen. The neurovascular bundle is defining by the letter A. This is the median artery and nerve artery. So if
Une petite seconde.
So if your instrument portal is localized to cranially, the risk is to create some intraoperative imaging, intraoperative hemorrhage, and to have some transient neuropraxia in the postoperative period. Do not forget major basic principle for arthroscopy, and the first one is the spatial orientation. Spatial orientation means that the proximal part of the joint should be always localized on the top of your screen. And that's, you can see here with the stifle arthroscopy. Usually we are starting the stifle inspection in the proximal pouch of the stifle joint. And the first picture that you may have is this one. The patella should be located above on your screen, and the trochlea of the femur is located down. A second major basic principle of arthroscopy is the four-oblique vision. All the arthroscopes used in canine arthroscopy are 30-degree four-oblique arthroscope, meaning that the tip of the arthroscope is beveled at a 30-degree angle. And beveling the tip of the arthroscope will increase the surgical field and allows for examination of a larger part of the joint just by rotating the arthroscope. And rotating a 30-degree four-oblique arthroscope will finally provide an 85-degree field of view. This is an example of the use of the four-oblique vision applied to stifle arthroscopy. So we are starting the stifle joint arthroscopy in the cranial compartment. This is the proximal compartment, sorry. We can see on the arthroscopic picture the proximal part of the patella and the end of the rectus femoris tendon. Then, if you use the four-oblique vision, the light cable is finally turned in an anti-clockwise direction, and without moving the camera head, you can have a look on the medial compartment of the stifle joint, and you will see the egress portal. And you can do the same thing on the other side. So you can turn the light cable in a clockwise direction, and you will see finally the lateral part of the stifle joint, and you will have a look on the lateral ridge of the trochlea of the femur. A big principle in arthroscopy is the triangulation principle. The triangle principle means that the tip of the arthroscope and the tip of the instrument should form the apex of a triangle. And if the triangle principle is correctly followed, normally the tip of the arthroscope, the tip of your instrument should be always visualized during the arthroscopy. And this is an important point. Do not triangulate when you create your instrument portal. Because if you triangulate when you are outside the joint at the time of the creation of the portals, it's likely that you will not see correctly the tip of your instrument when you will be inside the joint, because the tip of the instrument and the arthroscope will cross to each other. So my advice, when you create your portal tract, use an hypodermic needle and introduce the hypodermic needle perpendicular to the skin surface. And then when you use the scalpel blade to create the portal tract, just follow the hypodermic needle. When you are inside the joint, then you can triangulate.
Je m'en charge.
So the rule is finally to triangulate when you are inside the joint, but not when you are outside the joint. Finally, another important basic principle in arthroscopy is to maintain a functional outflow during all the surgery in order to
J'ai du mal à
avoid,
entendre.
extravasation of fluid and to avoid to have a loss of the visibility on your screen. Like for any other surgery, training is needed in order to become an arthroscopic surgeon. And in 2009, the ACVS and the ECVS updated the training requirement brochure for surgical residents in order to include arthroscopy cases. And this change in the training requirements highlight the commitments of the ACVS and the ECVS to ensure that the surgical residents are well prepared for arthroscopy surgery. So if you want to be trained, just follow some arthroscopy courses and do not forget to rehearse. Novice arthroscopic surgeons tend to be trigger happy when they succeed to enter inside the joint and may forget the ongoing development of potential intraoperative complications, such as cartilage injuries or extravasation of fluids. Cartilage injuries remain, in my opinion, the most common and deleterious complication in small animal arthroscopy. Cartilage injury has been recognized as a source of pain in the immediate postoperative period in humans, and is promoting as well the development of osteoarthritis. Prevention of iatrogenic cartilage injuries should be the main objective for young arthroscopic surgeon, and prevention requires a meticulous surgical approach. And for limiting the risk of cartilage injuries, it is important to have a nice distension of the joint, to have a walking space before placing the arthroscope and the instruments inside the joint. And secondly, it is as well important when you use some hypodermic needle, like pink needle, as a guide for the placement of the instruments. Do not push too deeply the hypodermic needle, because the tip of the hypodermic needle can finally cause some laceration to the articular cartilage. The extravasation of fluid is another intraoperative and common complication in canine arthroscopy. Even if the extravasation of fluid is a source of pain in the immediate postoperative period, it's not really a big deal for the patient. It is more problematic for the surgeon, because the extravasation of fluid in the periarticular soft tissue structure is causing joint collapse. And joint collapse will induce a loss of the walking space for the surgeon. And this is particularly true for shoulder joint arthroscopy. So you need to have a look on that during the surgery. The extravasation of fluid may be also a big problem for the surgeon if at some point unplane conversion to arthrotomy is required. It is much more difficult to do open surgery when you have an accumulation of fluid in the subcutaneous tissues. Prevention of fluid extravasation should be as well, like the cartilage injury, one of the main objectives for young arthroscopic surgeon, and prevention of fluid extravasation require mainly to maintain a functional egress portal during all the surgery. Caution is recommended every time arthroscopic instruments are inserted into a joint. In arthroscopy, we use small diameter instrumentation, and this instrumentation is very weak. So caution is recommended, especially if you do not use some walking cannula, and if the surgeon is using some open instrument ports. The distraction forces and the curvature of the articular surfaces may predispose to instrument bending or breakage. If at some point you need to deal with broken instruments, my first advice is first to reduce the inflow of fluid, just to reduce the turbulences inside the joints, and just to avoid to have your broken metallic fragment, which is migrating out the arthroscopic field. Maybe if you have one, you can use as well a magnetic retriever. It is just a magnet that you can introduce through the instrument portal, and the goal of this magnet is just to fix the broken metallic fragment in order to avoid the migration of these fragments. And then as soon as the broken metallic fragment is fixed inside the joint, you can introduce a second instrument portal like grasping forceps to extract the metallic foreign body. It is, I would say, definitively better to learn from mistake of other surgeon, but at some point, every surgeon should deal with his own complication. And look at this plaque saying that good judgment come from bad experience, and a lot of that come from bad judgment, meaning that we need to learn from our complication in order to repeat the same next time. In conclusion for this webinar, even if arthroscopy remains an exciting procedure for the surgeon, the main objective of arthroscopy is to provide some benefits to the patient. And this requires a case-by-case decision-making process in order to determine the role to give to your arthroscopy. Defining the role of arthroscopy is one of the keys to success and may avoid unnecessary surgery for the patient, unsatisfied owners, and a frustrated surgeon. Remember, arthroscopy is not a no-complication surgery, and intra and postoperative complication may arise. This complication may occur at any steps and are often cumulatives. So to limit the risk of complication, you need to be trained and do not hesitate to rehearse. Finally, be honest. You need to learn from your own mistakes and wonder if you should do the surgery. If not, do not hesitate to seek for other opinions. Thank you, everyone, for following this webinar, and I will be more than happy to answer to your question if you have some.
So thank you so much. As you've demonstrated quite nicely, arthroscopy is a technically challenging procedure to perform. And you commented earlier that as we get more and more experience, we become better technical arthroscopists. How many arthroscopy procedures do you think it would take to become confident in the field of arthroscopy?
The learning curve is definitively not the same for all joints. I mean that the learning curve is definitively steeper for stifle arthroscopy or shoulder arthroscopy compared to the elbow arthroscopy. If we referred to the commitments of the ACVS and the ECVS, surgical residents have to do about 20 cases of arthroscopy over the 3 years. I would say that this number is probably enough for elbow joint arthroscopy, but I would say that this number is probably insufficient for shoulder arthroscopy and stifle joint arthroscopy because the learning curve is again steeper for this procedure.
Very good. I think that is so true of the many endoscopic procedures that we perform. And so I think training is such a valuable aspect of developing proficiency as any sort of endoscopist. We have at CSU Vet CE a number of courses available in arthroscopy. We do have some equine arthroscopy courses coming up in August. There's a number of orthopedic courses that are not endoscopic that are also coming up in August and September. And then we do have some great endoscopy courses. There's a feline endoscopy week coming up in September, and
Great.
laparoscopy courses in October that people who are interested in this particular webinar may be interested in. I want to thank you, Jean-Guillaume, for your presentation. We appreciate
welcome.
your willingness to contribute to Endoscopy Talks. Next week, we have a special edition of Endoscopy Talks by our very own Dr. Eric Monet, and he'll be speaking on the clinical applications of ICG in small animal minimally invasive surgery. A special thanks goes to the Taiwan College of Veterinary Surgeons and to Scutum, which is Taiwan's distributor of Karl Storz products, for sponsoring this special edition. That session will take place on Friday, July 23rd. We look forward to seeing you then. And in the meantime, we wish you all the best of health. Thank you very much.